This is the Neurosurgery Podcast.
Hi guys, so I'm still here, Lima, Peru, with good friend Mike Kaiser.
Glad to be here.
Mike, we are about the same year, right? I think maybe you're a year ahead of me in training.
Maybe. I graduated Columbia in 2000 and then went to Emory and graduated from that fellowship in 2001.
Right, you were one of Praveen's early fellows.
No.
Oh, Reg. You were a Reg Haid fellow.
Reg, yeah.
Yes, because
So Reg and Rusty were my mentors in Atlanta. And then Praveen followed me.
Oh, he's a fellow behind you?
Yeah.
Okay, great.
Yeah.
Well, we're here in beautiful Lima, Peru. Mike Kaiser is the vice president of the Society of University Neurosurgeons. We're here at one of their meetings. Yeah. So, Mike, you were at Columbia for not only training, but most of your career, right?
Correct, yeah. I was there for residency from 95 to 2000.
Okay.
And then went to Atlanta to do my fellowship. And then I returned to become a member of the staff in 2001. And then left in 2019.
So 18 years at Columbia, and then now into NYU?
Yeah, correct. So Columbia always had a practice both based in Jersey and in New York. And in 2019, circumstances were developed such that myself and several other members of the department left and went and stayed full time with our New Jersey branch.
Okay.
And in about 2020-21. Reached out, talked to John Delfinos from NYU, and became part of the staff at NYU.
Great. John's a great guy.
Oh, awesome. Yeah.
You guys hosted the Suns a couple years ago.
Correct.
Yeah, amazing meeting in New York City. So I wanted to touch on something that I know that you've been an expert in, although you do a lot of things so well. You do spine surgery, obviously, and you kind of were like the go-to spine person at Columbia for a long time, right? I mean, there are a lot of people. There are a lot of people in New York City.
I mean, look, Paul McCormick is the man behind the machine at Columbia from a spine perspective, but they've got a lot of great people there. And I kind of came as Paul's second in command after my fellowship. And yeah, it was pretty much working with him closely and some of the other guys like Pete Angevine, Chris Manigo, Fred Ogden, until I left in 2019.
But you built an enormous practice in the New Jersey, New York area, right?
I would say it's a decent practice. Yeah.
And to me, that strikes me. I mean, Miami is kind of like New York South, right? New York City in that sort of area has to be the most competitive healthcare environment in this hemisphere. Yeah, it's intense, right?
I mean, within the city alone, you have how many, tertiary care academic programs? You have 4, right? I mean, there's NYU, there's Cornell, there's Mount Sinai, and Columbia. Mm-hmm. And then in Jersey, right across the bridge, you have Hackensack Medical Center, which is, a major institution as well. So there's a lot of competition, not only within neurosurgery, but also orthopedics, right? Yeah. I mean, and in fact, there are so many private practicing orthopedic and neurosurgeons that I always find that it's the private practicing guys that are more of my competition than it is the academic guys.
I mean, there's got to be in that area like close to 1,000.
I mean, there's a
spine surgeons, right? It's a lot of guys. So I want to talk about how you did that because, and I know everybody's got their trade secrets, about what they do, but how does a person? A lot of folks they're struggling. They're like, oh, I need perfect reviews, 5 stars. Oh, I need to be on social media. Oh, I need to give everybody my cell phone number. Tell us what you're from the Columbia model, so it's a very distinct brand.
Yeah. So Columbia is originally my practice was based out of Columbia. So you do benefit from having the tertiary care center bring in referrals and. Again, for 5 years before Pete Angevine joined us, I was the second in command to Paul McCormick. So, I got a lot of those referrals. But I've always based my practice on making sure the patient knows that you're their primary advocate, right? I mean, it's spending the time. I mean, I don't, in my practice, see patients less than a half an hour, and I spend time with them, I talk to them, and that's time consuming, but really let them know, educate them regarding their pathology, and what potential options are, and using surgery as the last resort. I think in my area, I've kind of been developed my practice such that I'm now known as Mike's the conservative guy. If you don't need surgery, he's going to tell you that.
Right.
And that's kind of how I base my practice. Kind of making sure that we use surgery as the last resort, and that it's absolutely necessary, and educating the patient regarding what the expectations regarding the surgery will be. Right. So in other words, people who have a horrible myelopathy from, let's just say, OPLL, they're probably going to be left over with some neurological deficits, right?
Right.
No one ever comes out of that 100%. Make sure they know that, make sure that they come out of the surgery knowing that, yeah, I have some hand numbness still, that's to be expected, or like if I do a lumbar fusion, I generally do those more open still. But my party line to patients is generally letting them know that at first your back's going to hurt you a little bit more.
Right.
And so when your back hurts you more for the first 2 to 4 weeks, that's to be expected.
Right.
So again, I kind of prepare patients what I think is going to be the reasonable outcome from their surgery, and I think they appreciate that.
And how do you deal with all the folks, I'm sure they come into your office, that they clearly don't have surgical pathology, right? Do you still have to spend all that time with them?
So for my new patients, I spend that amount of time.
Really?
And again, I don't have a practice in which on a busy day, I'll see maybe 20 people.
Okay.
Right? But I'll do that multiple days over the week.
Right.
I just don't have one clinic day. And then I will pepper patients throughout the week as well.
Oh, wow.
So the big advantage of now where I am is my office is located within a mile of my hospital, within a couple of miles of where I work. So that is an advantage for me to have, where I can just pop in the office very conveniently whenever I have time, in between cases. So my patients are scattered throughout the week. I have 2 major clinic days,
right,
and then I'll see patients throughout the week as well.
I noticed Rick Komitar does that. He's the only one that does that in Miami.
Right.
And is that because it's easier for patients to access you, or because you would spread the, I don't want to say the pain, but like
the salt mine.
The
And then love being
over the week.
Love being in the office. I actually enjoy sitting with patients, talking to them, getting to know them. I like to make it like personal. It makes it easier that way, and it allows me to spend the time with the patients more. So my follow-ups will be shorter, 15 minutes generally, unless there's a problem. But new patients are 30 to 40 minutes.
I have the opposite philosophy.
Yeah, I know. We've talked about this, and I know, like you're, and that's why I contrast my practice to yours, because you are so busy. You're busier than I am.
Well, it's different. I mean, I think maybe you probably screen a little better. Like
used to. No, I don't screen anybody anymore.
Oh, really?
No, we bring everybody in. And so like early on when I was at Columbia, I would look at radiology reports and say, what, there's not really any surgical pathology here, so why don't we just have them see somebody else first? It's a little different that I'm now primarily practice, practice-based, private practice-based, where, they want to see the doctor. Right? And so, yes, I have nurse practitioners, and they're great, who will see the patient sometimes if there's no imaging. But if someone has imaging, I generally will bring them in and see them myself.
So that's so interesting, because most people that I know, right, what they do is they start out being like very hungry and they want to see everything. Mm-hmm. Then as they get busier, they try to filter everything to be perfect. No re-ops, good insurance, right? Psychosocial, smoking, obesity. Right. And then they always say the perfect clinic is 10 patients in the clinic with 10 surgeries booked.
Right.
And that's not what you're doing. That's definitely not what I'm doing.
Yeah, I don't do that either. I see everybody. And my hit rate is probably, I tend to be more conservative than most in my area, I think. It's probably on the order of, like, at best 25%, 20%
So
or less.
1 in 4?
1 in 5 maybe. And that's, on a good day, I'll see a couple of patients that'll book for surgery. But in general, it's down in the 20% or less hit rate range. Yeah.
That's almost like an old school type practice from like 50 years ago.
Yeah, I kind of enjoy that. Like I said, I build a relationship with the patients. And the thing is, though, they might not need surgery now.
Yeah.
But I have a pretty high return rate, too. Like, people will come back to me.
They trust you.
Yeah. That's a good way to put it. Like, you want to develop that trust. And like I want to get up in the morning, be able to look in the mirror and say,
you're doing the right thing.
In my heart, I know I'm doing the right thing. And you know where I get that kind of mentality from? Reg Hay.
Yeah.
Reg was such a great mentor that way. And I still love the guy.
He says he reserves every Thursday or has something to have lunch with a patient or something like that.
Yeah, I don't do that. but Reg instilled that in me, where he was just like, during my fellowship, and Rusty was great too, but Reg really had that mentality where it's like, look, you want to be able to feel like you're doing the right thing.
Yeah. And
it's not to sit on an ivory tower and say you're better than anybody. It's just, look, everybody's got to figure it out on their own.
So I have kind of like the converse practice of yours, which is that I see an enormous number of people, like 100 a week. Okay, but I very quickly analyze them and try to give them like all possible opinions, but immediately. Like there's no real social connection, interaction piece. Like it's not like we're talking about, you know, a lot other than the critical parts, meaning like what they do for a living, what their goals are, and then quickly analyze and say, okay, these are your options, and then you can think about it, and then we'll move on, because then I feel like if I don't, then I'm taking time away. I hate to sound so arrogant, from the next patient. That I have a limitless filter that way I see 100 people a week, and maybe the hit rate is, let's say, 15%, right? But because of that, the people who don't need surgery, and so many people now are like, someone told me if I don't have surgery, I'll be paralyzed.
Oh,
and I'm like, no. You don't need to, this is a 5-minute visit. You don't need to worry about that. I'm not going to talk at length, but that's not actually factually true, right? And then I'm done, right? And I walk out.
Yeah, I'll spend a little bit more time with that person.
Yeah.
You know what I mean?
And sometimes they need that.
They just
really
need
need
to be like pulled off the ledge, right? Because they have in their mind, you know, if I sneeze, I'm gonna be paralyzed.
Yeah.
It's like, it's not true. But then you got to take them through that a little bit more. But do you do that all in one day, or like?
So I
know you don't see 100 patients in one day.
I say, like in 2 days, and I'll tend to be like, listen, go home and sleep on it, because I feel like people think when they're sleeping, and if they're not going to listen to me anyways, they're not going to listen to me. Right. But if they're going to listen, they're going to think about what I said. Then they often come back, even if they don't need surgery. Like, listen, I'm not going to answer all your questions, but you know, you're back. Mm-hmm. What is on your mind? And then they'll say, okay, well, here's the thing. My job needs this form filled, and I'll be okay. Got it. Okay, so I'm very sort of like practical. I like to be pragmatic, you know, about it. But I like your style, because I think a lot of my patients are like left, and I know they're out there. They're like, you know, Dr. Wayne couldn't spend a little bit more time talking to me. I'm like, I feel like it's taking away from the next patient who needs to be talked off.
Yeah, when you're seeing that many patients, you have to do it. Right? Do you have an extender that helps?
Oh, yeah.
See, So I don't use my NP to see a patient, then I'll walk in the room.
Oh, okay. So, and I'll have them often come after me.
Right.
Say, listen, let them.
Well, they'll do the surgery. Like if they commit to surgery, then I have my NP and my admin.
I see.
And they do the booking and all that other stuff. After I've talked to them about risks and benefits, but. Yeah, you know, like in my area, I kind of want them to feel like I want to go back to this guy, because this guy has shown interest in me.
Right.
And to do that, I need that extra time. And then again, everybody just figures it out on their own. But that's kind of how I feel like in my hands. Just like surgery's a tool.
Yeah.
Patient consultations and interactions are a tool, right?
Patients like you better, I'm sure, than me. But
well, I wouldn't say that, but it's just in my area. And then like the one thing I will do is when they come in and say, you know, I saw this, I was like, don't tell me what the other guy said.
Don't tell me what the other guy said.
I'm going to tell you what I think independently, and we can discuss it afterwards.
You know, I don't even look at imaging.
Oh, before, yeah, I
do not look at anything.
Look at imaging before I ask them. And what's your, like, from my party line when I see them, don't tell me what's on a report. Don't tell me what a doctor said you had. What are you feeling? What are you experiencing?
Exactly.
And then I can tell you whether or not that correlates to what we'll see on the image.
So this is so good. I didn't plan to talk about this, but this is, okay. So I have 6 junior partners in neurosurgery.
Right.
Every one of them did fellowship and or residency with me.
Right.
Okay, and Alan Levy. So I know them inside out, right? They're struggling a bit. And when I talk to any young spine surgeon, they are all kind of struggling, unless they've already gone into the sociopathic, like evil, like criminality world, right? Like, you know what I'm talking about, right? Those people have like a different mindset now. They're just predators. But for people who are really honest, I mean, like this, did you see that Gooby Dooby video about like the spine surgeon with all the mosquitoes he's swatting? He's like, I realized spine surgeon.
I didn't see it.
It got like 10 million views, and I was like, this guy's crazy.
Yeah.
He basically says spine surgery's rotten to the core, and I sold my soul for it. I'm like, that's crazy. Like, you and I didn't do that.
No.
You do the right thing.
You don't have to.
You don't have to do that. So I feel like the young people are stuck in this rubric where they're like, oh my God, I got one bad review and now I'm a 4.7.
Yeah.
Or they're like, somebody said something about me, or, you know, how I can't compete with other people. Like, what is the solution for that as a
secret sauce, right?
Secret sauce as an experienced senior master surgeon.
One, I wouldn't say I'm a master surgeon, right? But just be honest with the patient. Make them feel that you're invested in them, and spend the time. I mean, I guess that just really being a doctor in a way. You know, you're a doctor and a surgeon, right? And again,
doctor first.
Right, you're a doctor first, and you want to show that, you know, you're interested in their situation. They're not just a number. They're not just a patient on the list of surgeries for the day.
Right.
And you know, everybody's got to figure that out on their own. But I always tell, like, when I was training residents more regularly, I'd say, look, when you go out, don't be aggressive about recommending surgery. Make surgery the last resort. Spend the time with people. Be available, right? Affability, availability. You know.
Right.
I mean, these are the things that I think people, from a human perspective, will attach to. And if you can generate that kind of mindset in patients that have seen you in the office, they'll go out and they'll say, "You got to see this guy."
Right.
And that's where you want your word of mouth referral to be based on. And again, not to say that I'm the best in the area, but I will have a lot of patients that come to me and say, yeah, you operated on so and so. They said I had to see you, right? And you're the guy to see, right?
Mm-hmm.
And look, you do MIS. You're the world's expert in that. I do certain things MIS, but I really don't do lumbar fusions MIS. I just still do it. It's a little bit old school.
Mm.
But I still have a lot of people that come to me for a lumbar fusion and I'll say to them, look, I don't do this MIS, but they do well enough where it's like it's okay with them.
Oh yeah, I still do a lot of open surgery. Yeah.
And so, but that's where I think it's generating that referral-based word of mouth that is, he's going to give you an honest opinion. You're not going to walk in there and he's not going to tell you need surgery right away. And then you want them to go back and tell their referral source, whether it's a pain manager, specialist, primary care doctor, that, yeah, he gave me an honest opinion. He's not rushing me to surgery. And then the next thing I'll do is I always send the referral source a letter. I don't just send them my office note.
Yeah.
I send them a personal letter.
Okay.
Yeah, and again, I don't see as many patients as you, so maybe that's like 20 letters a week or something like that. But they'll all get a letter from me saying this is, summarizing my thoughts.
So as we close this up, I do want to say that, like, I have enough penetration into the New York area in the sense that people are going back and forth enough that I hear enough about what the different doctors do up there, and that you're doing an amazing job. So I do consider you a master in this field. But I want to get your thoughts on, obviously everybody's talking about AI, right? Like, AI is big in healthcare. You've seen the studies that came out last year that showed that most patients actually find AI to be more compassionate than physicians, right? And this was what the old doctor said, well, that will never happen. Right. And of course, that's the first thing that happened, right? So what are your thoughts about where we're headed with all this, in spine particularly?
Yeah, I mean, AI, it's something that we're going to have to accept. It's coming down the pipe no matter what. I mean, it's funny, I'm just reading an email from my staff. We tried to use AI as the front desk person.
Yeah.
And it wasn't so much that from an emotional perspective, it couldn't interact well with the patient. It just, with the way our office practice works, it's not centralized, so we're having problems having the AI figure out how to schedule it, because everybody kind of schedules randomly and stuff like that, so that's where it's more difficult. But yeah, I mean, giving opinions about something, and if AI can generate that online, in particular, people are going to come to the office much more informed, and you have to be prepared to justify what you're going to recommend. I mean, it's almost like AI, I think, is going to be used as a resource for people, and then they're coming to the office more educated. And you have to be prepared to be able to justify what you are telling them or recommending, what they need.
Yeah, I agree with you. The only problem I have with AI is that its source of information is biased.
Right.
So if a spine company selling, let's say,
they can infiltrate the web with so much material that the AI is going to latch onto it.
That's exactly what's happening. People are coming and asking for the procedures.
That's exactly right.
That Google up first, right?
Yeah.
Like a mild procedure, right?
Yeah.
Like, oh yeah, AI says a mild procedure.
I mean, so many patients, like I see a lot of neck, right? I mean, I love neck, cervical surgery. And a lot of people will come to my office just wanting an arthroplasty. They're, look, your spine is just too degenerated to support that. Or it's not going to work, in my opinion, well enough. And again, that's just my opinion. But yeah, they are coming informed through AI. And it's just something where you have to be on top of things so that, again, you don't want to feel like you're selling them on something.
I finally feel like we're like the primary care doctors where people are like, well, I saw this commercial for Skyrizi, and like, do I need this for my skin?
Oh my God.
Or like my sleep apnea, whatever. Like, we never had that in spine. We just had the other BS, chiropractic and all that. But now we've got this, and like, maybe it's time to retire. Like,
I know. I mean, you think about it that way. But that's the other thing. I mean, you mentioned chiropractic, and that's the one thing I've learned now, being primarily private practice based. You got to embrace these. You got to embrace everybody. And everybody has a value, right? I mean, you don't want to just sit there and say, chiropractors. No.
It has its role.
It has its role,
Sure,
and you better
sure.
accept that. And
Yeah.
everybody has a role in order to maximize, what the patient needs. And you may or may not be part of that as a surgeon. You just have to accept that.
You better learn how to do some dry needling.
Yeah, exactly.
Well, Mike, thank you for coming
awesome.
on the podcast, being generous with your time.
Yeah,
and
my pleasure, man.
Congratulations on your leadership in the Sun.
Same to you, as always.